Okay. And the next case, we have the diagnosis of psoriasis. Actually, psoriasis, we usually, in the regular sign out, we won't usually just put the diagnosis like psoriasis there. We always use the term psoriasiform dermatitis because it's not really specific unless we see the clinical picture is really classic for psoriasis. And another clinical problem is that if the dermatology, even the family doctor thinking about psoriasis, they usually do not biopsy that lesion. So we in the clinic we usually not see really classic psoriasis. But in the text, I think this is classic psoriasis. So to make the diagnosis of psoriasis, you need several features. First is this is a conventional like regular psoriasis. So we can see this parakeratosis confluence. That means most of the lesion, we can see this parakeratosis here. Then we have under this parakeratosis, you can see the granular cell layer diminish. That means usually we will see a little bit purplish in this granular layer, but in psoriasis, under the parakeratosis, you could not see really clear purplish area. That is the hypogranulosis. Then we usually do not see spongiortic dermatitis. But if the patient feel kind of itching, they scratch, you will see that, like here, just a little bit. But the spongiortic would not be your main thinking in this psoriasis. Then we have this regular elongation of the reedy. Regular, that means we have the same level of all the reedy ridge, like here. That is regular. Regular for the psoriasis. So we have three pattern, confluence, parakeratosis, and then when we zoom in, we usually can see neutrophil. Somewhat like here, this is dark nucleus to be neutrophil. We can see this binucleated, that is neutrophil. So neutrophil in the stratum cornea layer is the characteristic of psoriasis. Then you can see this granular cell layer kind of diminish under the parakeratosis. Then we can see this dilated vessel in this dermal papillae. So this make you think of in the clinic when the dermatologist try to scratch the plaque of this psoriatic lesion, you will easy to see some blood because when you take something out, it's really easy to break this vessel. So all of these feature is psoriasis. So I think the most important thing is the parakeratosis and the neutrophil inside the para. And then low power with regular psoriasiform. That is the reedy in the same level here. So this is psoriasis. I think I have different, okay. This is called the guttate psoriasis. Guttate psoriasis kind of mimic the previous one, that is the pityriasis rosea. I think this one is not that good. Usually they also have this mounted parakeratosis here. Let's see whether we can see. Yes, for this one we also have a little bit mounted keratosis. You can see the nucleus still in the stratum corneum here. And then we can see some neutrophil. This is bilobated neutrophil in the stratum corneum. And then you ask me why we do not see any psoriasiform irregular elongation of the reedy. That is one of the tricky thing for this diagnosis, guttate psoriasis. You do not have perfectly elongation of the reedy. You can see here, you can see a little bit elongation, but the pattern is not really like the psoriasis. I don't think it has, they will give you this one to make the diagnosis, but just would like to draw your attention. Not only the pityriasis rosea can have this mounted parakeratosis. Other dermatitis we also have this. So we also have parakeratosis, neutrophil, a little bit elongation of the reedy, and also this dilated vessel. just in the dermal papillae. Also another characteristic feature. Then you can see in guttate psoriasis, you still can see this thickened granular cell layer, but under the keratosis area, you can still see maybe a little bit diminished thinning of this granular cell layer. But go back to the previous one. When you see conventional psoriasis, when you see this para, the granular cell layer should be really thin. You cannot see this thicken of the purplish granular cell layer.